Yes, sir.
We start the recording. Good evening, friends. This is IPS Vadodara branch as well as Bombay Psychiatric Society hosting yet another session of Brain on Wednesdays. The topic today is obsessive compulsive traits, development, vulnerability, and pathology. To chair the session is Dr. Aparna Ramakrishnan, who has done her postgraduate studies from Father Muller Hospital and Medical College at Mangalore in 2010 and 11. Subsequently, was a senior resident at St. G.S. Medical College and KM Hospital, did assistant professorships at D.Y. Patil Hospital and School of Medicine, as well as Government Medical College and Sir J.J. Group of Hospitals. And presently, since 2019, he is working with the Kokilaben Dhirubhai Ambani Hospital and Medical Research Center at Bombay. Aparna, chair the session here onwards.
Thank you so much, sir. I would like to start the session by thanking IPS Vadodara, by thanking the Bombay Psychiatric Society, particularly Dr. Rajkumar sir, Dr. Bhaskar Mukherjee, Dr. Malay Dave, and Dr. Rukshada Saida for giving me this opportunity. From the time of inception of Brain on Wednesdays, I have tried to attend as many sessions as possible, and I think I've come out being a better psychiatrist after each session. And just a small anecdote on our speaker for the day, Dr. Bhaskar Mukherjee. So I had connected with him, asking him for a couple of details by which I could introduce him. And he very humbly said that he doesn't like such things before presentations. So that's when I realized that Dr. Bhaskar Mukherjee does not need any introduction. Now, clinical molecular neurosciences or psychopharmacology, I think he is one of the most eminent experts in this particular country, in this particular field. So without further ado, I invite Dr. Bhaskar Mukherjee to kindly start the session. Thank you.
Thank you for keeping my request of not giving any introduction, because introductions are like, look, these and these are my credentials, so you have to listen to me. No, nobody has to listen to me. It is their own choice. If they want to learn, then they are welcome to listen. Otherwise, it's okay. So with this, I would start today's session. And let me give some understanding of today's session. Today, it would be more like you would feel that there is extempore going on. Why extempore? Because deliberately I have not made any presentation today. This topic needs you to listen to my word, understand it, and throw back your questions. Because this topic, if I give it in a didactic lecture format, it would not do justice to this topic, because today we are going to trace the path of neurodevelopment that starts in the womb and later develop as vulnerability trait for our patient. Last time I have talked about how different manifestations of sickness behavior happen due to various molecular pathway as well as various connectomic pathway. This whole series is an effort to elucidate that psychiatry is nothing but signs and symptoms of brain diseases which can be compiled in a single phenotype. A single unifying phenotype is sickness behavior. In past session, I have elaborated what is sickness behavior or illness behavior and how that happens, what is the evolutionary basis for that, and what are the different expressions of it. In second session, we have talked about what are the background players that create this sickness behavior In third session, I have discussed about how in molecular pathways and how in various brain pathways the collaboration happens which create the sickness behavior. In this fourth session, I will try to point out the various things that indicate this vulnerability trait in a pregnant woman, indicating that the offspring is going to be developing these traits. Then we would trace it to early child development period, means just immediate after birth, then 10 days, then first 6 months, then first 2 years, and so on. So here I would be more interested in telling the phenomenology. Next time means next episode, I would be showing slides because there I would discuss how the molecular pathways and brain pathways and whole body pathways correlate to form this evolution. Today it is knowing the state evolution. So this is the backdrop I wanted to create. So standing there, let's start with understanding that the psychiatric symptomatology actually starts from pregnancy of mother. When a woman goes into pregnancy, there are various signs and symptoms, and each of them indicate vulnerability trait in the child. So first trimester, what are the things to look for in first trimester? Pregnancy associated vomiting is very common. It happens in almost 99% females. But once that vomiting period goes for 2 to 3 months and then it gets over. And that vomiting period doesn't normally destabilize or debilitate the matter enough to cause disruption of the mother's regular life. If this normal emesis goes to such extent that it causes, number one, severe destabilization in mother's life, functional impairment, occupational impairment. Then number two, if it is such excessive that mother needs treatment for it or suffer various kind of consequences like water electrolyte supplement and other thing, or if it persists beyond the usual 2 to 3 months, this three sign would signify that the mother is carrying a child who has genetic vulnerability for developing various forms of psychiatric disorder, which totally we can call sickness behavior and its variant. So that is the first sign. Then what other first trimester sign we have to remember? If there is history of spontaneous abortion in mother within first 2 to 3 months, and if the abortion is not due to any particular traceable fact, if the abortion is not due to any form of trauma, trauma means physical trauma, or if the abortion is not, or rather is accompanied by some phenomena like blighted ovum, untraceable fetal heart rate even after usual period, and there is multiple history of similar, then that is another vulnerability period. The third vulnerability is most patients have slight tachycardia and a slight rise of BP during first trimester. But if that goes over and above that, if the BP starts rising from the first trimester, then it is also a warning sign. The next warning sign is of diabetes. If gestational diabetes starts in first trimester, then that also signifies that fetus is carrying various vulnerability trait. The second, then comes the second trimester. Usually in second trimester, there is fluid accumulation. So some amount of swelling is expected. Usually in second trimester, there is some form of rise of BP in some patients. But if in second trimester there is persistent bleeding, if there is low-lying placenta, if there is threatened abortion again, if there is spike and rise of BP as well as spike and rise of hypertension as well as newly detected hypothyroidism which continues, then that is again a vulnerability feature for development of our diseases in future. The third trimester. In third trimester, any form of preeclampsia, any form of polyhydramnios or oligohydramnios, any form of cord around neck, any form of fetal distress which is inexplicable due to various conditions, or any other deviance like persistent breech presentation signifies that this patient is going to develop neurodevelopmental problem in future. This patient means this baby. Now, the more vulnerability profiles are there, the more chance of it happening earlier and earlier. Let's say if a mother develops gestational diabetes, preeclampsia, as well as there is low-lying placenta and multiple episodes of bleeding, then this mother has a very high chance of delivering a fetus who is going to develop various neurodevelopmental problems in early childhood compared to a mother who has only rise of hyperthyroidism or hypothyroidism. There is only signs of hypothyroidism in second trimester. Both are vulnerability, but the more the vulnerabilities are, the more there is chance of developing the deviant trajectory sooner. So this is the first pregnancy red flags. We need to understand these red flags because of following practical reason. Number one, Unfortunately, most of the times, if mother is taking our medication, then our medications are blamed for it. Number two, if these symptoms develop in a mother who is taking our medication, then we can stay prepared that the baby is going to develop some symptom or full symptom of mother, and there we can be preemptive in offering various treatments. And lastly, if we know these vulnerability features, then we can communicate with the gynecologist. We can treat the mother better by increasing her doses of psychotropic. And if the mother is not on any psychotropic, then we can offer the gynecologist some understanding that probably offering psychotropic is the way to help the mother and baby, because psychotropics change placental parameters, psychotropics change placental epigenetics, and various other placental genetic profile that might give the developing vulnerable feature some advantage. Now, after this comes the first serious problematic stage during, that is, labor. Any mother who develop this kind of obstetric problems during the pregnancy has a high chance of developing various labor problems. They frequently would develop either premature contraction, or they would go into delayed labor. There would be either hyperactivity of uterine muscles or low activity. Similarly, they would have high chances of postpartum hemorrhage. They would have high chance of postpartum uterine inertia and things like that. And so they would frequently be undergoing cesarean section more rather than other mother whose baby or who herself are not carrying this type of vulnerabilities. So during pregnancy end, that is childbirth, we have to be aware that these patients have a higher chance of cesarean section. And in cesarean section, the first baby outcome would be delayed cry. Many of these babies come up with delayed cry. Why? We don't know. Possibly mm, mm, mm. Why we don't know? There are a lot of reasons, because in next part of this discussion, means the next episode, I would show various biological mechanism by which these babies would have higher chance of neurodevelopmental problems, and those might explain the delayed birth cry. But surprisingly, more number of babies who are born with this type of vulnerability has delayed birth cry, low ABGA score, and that low ABGA score persists in during reassessment. This is the first observable vulnerability trait in baby. Next comes the prolonged neonatal jaundice. In many baby, neonatal jaundice is normal and that appear after third day, and that clears within 3 to 4 days. In these babies, the jaundice would be either very high, almost endangering or exposing the baby to the risk of kernicterus, or it would be more prolonged, or it would appear early. This would be the second sign that we should look for. Then there is also increased chance of infection within first 10 days. That might be umbilical stump infection. That might be infection in GI tract. Then comes the early neonatal period sign. First 6 months would come with a host of recognizable deviant neurodevelopment. First would be delayed establishment of sleep wake cycle. Normally, once birth has happened, the baby actually develop normal circadian rhythm within 2 weeks. Initially, baby would sleep whole day, but within 2 to 3 weeks, baby would start sleeping in night mode and daytime sleep would reduce. And slowly, ultimately, the trajectory would go in such way that the baby stays awake during daytime most of the time and sleeps at night. But in these babies who are carrying the vulnerability, this normal transition would not happen. They would go into sleep more during daytime and then they would stay awake at night. They would feed more at night. They would be more active at night. They would be more cranky at night. And many of them would need special care during night throughout the first 7 months. And in those who have higher vulnerability, it goes up to few years. There are babies whom I am following since their birth who have not slept normally even at 5 years. And this is a very common but missed observation. Then comes the second thing. What is the second development? Most baby start recognizing mother within first 2 months. And that is actually a very memorable thing for any mother. Even for a multipara, multigravida woman, when her baby started recognizing her is a memorable event and she would be able to recover, remember every child's day of doing that. These babies have a problem with that. Some of these babies actually start recognizing mother earlier. If they do that, then we are looking at something that would later develop into externalizing part of signal behavior. If in other group of people or other group of infant, the other thing happen. They start recognizing mother late and late. Many of the children in this group recognize mother after 4 months, 5 months, 6 months. This is the group that would later go into developing so-called autism-like symptom, which is again another part of this total sickness behavior. Then comes the third manifestation. The third manifestation is frequent GI disturbance and food related problems. These are the babies who do not suck properly, who would not be able to suck properly or would not want to suck properly, who would regurgitate, hmm, who would regurgitate food very often, and who would actually start vomiting whenever there is food. These are the less known effects, but they also happen. Then comes the other more recognizable things. More recognizable means these would be child who would not crawl. These would be child who would not be able to hold their head properly. This would be child, something is happening with screen. A lot of movements are there. Odd, I don't know what is happening here. Anyway, so this is significant of significance because this indicates possible myopathy. This indicates possible neuromuscular disorder, and this indicates possible some form of mitochondrial errors in our patients. And this is where we need to be vigilant because these things are normally missed by developmental pediatrician, developmental neurologist, and all because they don't study the perinatal period this minutely. This is our area. And this would give us valuable clue regarding what we need to do, how we need to do things, and what measures we can offer. Then comes the end of 6 months. By that time, we would have many pointers showing us in which way the child is going, whether there is prominent neuromuscular problem, more cognitive problem, prominent hypervigilance in the form of extreme crankiness and other things, or the child is not showing these things that much means there is variable penetrance of the vulnerability trait. Then comes the second part of vulnerability, the 6 month to up to 2 year. In normal area, normal child development, this is the area when the major motor milestones happen. Major motor milestones are always a crude indicator, but finer indicators are the child's preferences and the child's temperament. If the child is very finicky about the surrounding, very finicky about what likes and dislikes the child have, very finicky about communicating with other people, very particular, or not showing any of these, that are very, very fond of people, goes to every people every time, then both these extremes are example of deviant neurodevelopmental profile, and the child is going to express different spectrums of vulnerability trait. The one who are extremely jolly, extremely people loving, extremely less fearful about others, and pro social, very, very pro social, they actually have externalizing traits, or whatever name we can give that. And those who are not have started showing, and who are very finicky, very particular, they have started showing development of their obsessive trait or neurotic trait. Extreme form of obsessive and neurotic trait is actually our given name of autism spectrum symptom. Then comes the finer motor development. In coordination, if that is persisting too much, if the communication is restricted too much, if there is very poor walking tendency or other thing, then that would also point towards developing obsessive trait or the same vulnerability trait. Then there would be early school joining time, the next stage. By this time, the child would also show other signs like increased fearfulness and hypersensitivity towards any environmental change. During age, every child, when they start school, they get very, very anxious and they cry. That is part of normal behavior. When a normal behavior is not normal, rather exaggerated, when the child doesn't cry at all, when the child is very, very eager from the day one to go to school, or when there is prolonged cry, when there is prolonged refusal to go to any play school, when the child cries so much that the parent has to accompany the child for a prolonged period in the play school, then this is deviation. And these two sets of deviation indicate two sets of developing disruption in the child's brain. Again, I am saying I am just describing the clinical signs. And in next topic, we would discuss the brain background and brain pathology that might have been encouraging this. So today we are mostly talking about what clinical signs to look for. So this is the school joining period. Once the child starts school and the school behavior gets added to the observational part, there would be a lot of other things to look for. The disruptiveness in school, we all know, and I am not elaborating on that. If the child is excessively shy, if the child is a model child, means teacher's pet, extremely obedient, extremely minding to the rules and regulation of institution, and attend school hyper regularly, then actually that is the opposite spectrum of disruptive behavior, and the op- uh, then the externalizing trait that normally we look for. Every model child actually is carrying vulnerability trait for neuroticism. Then there is exam anxiety. Then there is development of various threat recognition and hyperactive response to threat. Around 5 to 6 years, child start showing discomfort to various sensory stimuli, various social situation, gets very triggered by various phobias and other things, and that again triggered, that again shows the vulnerability period there. Then comes the attainment of puberty. We are having very progressive puberty nowadays. Puberty is coming forward with each decade. Why? We don't. The adolescence period is covering more and more time in human beings' life. Previously, it used to be 12 or 13 to 19. Then puberty progressed towards 2021 in the end, and in the early side, it came down to 10 or 11. Now, by 8 to 10 years, most girls and boys start attaining puberty, and puberty goes on till 25 to 27 years. Why this change is happening, nobody knows. We don't know why this is happening. Are we getting more sensitive towards pubertal changes? Or really puberty is increasing? Or our concept of puberty is evolving? Any of the explanation can happen, or all of the explanations can maybe working together. During this period, the fast vulnerability traits gets exaggerated. If there is increased fearfulness throughout the prepubertal period, that would get a huge boost. If there is increased attention deficit or externalizing trait, then that would get another boost. If there is restlessness and other thing, that would also get a boost, and we would finally start getting the adolescence picture. Adolescence is the time when most of these vulnerable people start developing migraine. Migraine means we are talking about a set of cephalalgia or a set of headaches which happen during any environmental change, be it cold or hot, which happens during any emotional state change, be it extreme low mood or be it crying or be it anything, which happens during any energy metabolism change like prolonged fasting, which happens during any intense autonomic nervous system stimulation, And these headaches many a time are accompanied by either vertigo or temporal neuralgia like symptom, or they are associated with muscles of mastication pain, or they are associated with nausea and vomiting. Each of these have their own evolution. If there is associated pain in muscle of mastication and there is bitemporal tenderness, then there is associated compulsive throat grinding, and that has given rise to this symptom. If there is associated temporal neuralgia like feature, then we are dealing with a localized autonomically induced temporal neuralgia, the Suna headache syndromes, and that is again a sort of vulnerability indicating anatomical maldevelopment. If there is vertigo, then the affected area is mostly posterior circulation in brain, and so on. So the type of headache that starts in a person is indicative of other various things. In very severely vulnerable people, headache starts as soon as the onset of puberty, 9 to 10 years. In not so severely vulnerable people, it starts slightly later. Then comes the other pubertal accompanying features. In case of these people, there is autonomic nervous system hyperactivity. Puberty would be accompanied by resting tachycardia in many. Along with that, hyperhidrosis in the form of perspiration in this area, perspiration in hands, the soles and palms, or perspiration in those areas where heat exchange occurs rapidly. Thin skin, more vascular supply. This is one of the such area. Neck is one such area. Palm is one such area. Sole is one such area. That is why sweating happens more in these areas. So, along with that, there would also be increased body odor problem, and that would again happen due to their vulnerability expressing itself as increased apocrine gland secretion. Then there would be early incidents of GI disturbances. In many of them, the GI disturbances happens either in the form of diarrhea or constipation, or in some diarrhea alternating with constipation. Obviously, they are not thought as childhood or adolescent onset IBS. They are thought as recurrent attack of dysentery, recurrent viral diarrhea, and things like that. Because we don't know the vulnerability profile at all. There is very little, if any, work on this early developmental vulnerability profiles. So these initial IBS episodes are blamed to various viral infections. Then there is also other things in other body areas that would develop during this time or slightly earlier. Allergic asthma. Allergic asthma starts, there would be two groups of allergic asthma. One would be infantile onset. These are actually more severely affected brain disorder patients. There would not be a single patient of infantile onset allergic asthma who would not have severe neurotic trait, for the lack of better word, along with impulsive compulsive behavior. If you know anyone who has or had allergic asthma, which is infantile onset, you would find that the person is carrying severe neurotic trait along with impulsive compulsive spectrum behavior. Now, the adolescent onset variant is less severe, but it also denotes the same vulnerability profile. And these people would also have more obsessive trait and less impulsive compulsive behavior, but they would have it. Then the other allergic manifestation, recurrent hay fever, dust allergies, various other allergic manifestation, they would appear during this adolescence onset. Yes, there is a variant less known but less common. But there is an infantile onset variant too. But like infantile allergic asthma, that follows a more aggressive course. The usual onset is not that aggressive, but they also signifies the same brain vulnerability profile. Then comes the 14, 15, 16 years. Unfortunately, this is the time when in most countries the child undergoes the higher academic pressure. So most of the time, the higher academic pressure is attributed for this kind of symptom. But this is the time when severe exam anxiety would happen, severe school avoidance would happen, severe destabilization, severe drug use would start. This is the time when all the vulnerabilities would come together to create the first clinical symptom. And most of the time, it would affect the child's academic life, personal life, and everything. But unfortunately, in most of our nations, in any nation, specifically in our Southeast Asian nation, this is blamed for education. And people rather stop education in these people, in this child, specifically the low socioeconomic people, rather than going for treatment. This is the full vulnerability profile that we should be aware of. And there would be extreme variations of it. Means there would be a group of people whose inborn error of metabolism would manifest during early infancy to early childhood, and they would show these symptoms, but they would also develop rapid deterioration. This is nothing but one of the vulnerability cause or one of the causative thing coming out and killing the child. There would be a group of people who would develop epileptic vulnerability during this time, and they would going to develop into childhood epileptic syndromes, there would be a group of people who would have vulnerabilities, who would develop childhood febrile convulsion, and this febrile convulsion would be treated or untreated, and many a time temporarily treated by neurologists and then stop the medication. They represent a hugely missed chunk of people who actually are epileptic encephalopathies. So a lot of minor variation would happen. I wanted everyone who is present here, who is listening to it or who will listen to it in recording, to understand that all of these are actually vulnerability profile of brain. Brain creates all these profiles. A patient of childhood onset allergic asthma is as much a patient of pulmonology as he or she is a patient of brain or psychiatry. But they seldom get their treatment. Now, I know invariably a question would come: what would you do? Would you be able to treat this patient? Yes, we can and we should. But the journey is not easy because perinatology is mostly talk and needle medication. So during our job starts with collaboration, cooperation, and information campaigning to gynecologists and obstetricians. First, we have to take them into confidence. We have to talk with them. We have to create a dialogue with them. At present, they are insular in their own area. We are insular in our own area, and that is not helping the cause of humanity as well as the cause of brain. We need to create talk with them to make them understand that this is how brain dysregulation is going on, and that is manifested as mother's health deterioration as well as deterioration of intrauterine fetus. So our job starts there. We cannot treat fetus because there is no way of using intrauterine drug delivery for fetus, but we can treat the mother. We can offer the mother the treatment which would be passed on to baby. Then comes the teaching the obstetrician and the neonatologist the early signs of problem. How, when problem occurs, how it occurs during labor, and what to be done and what it signifies. You would be interested to know in last 5 to 6 years, a lot of study of neurodevelopmental profile in neonates and in these infants are going on. None of them are done by psychiatrists or perinatal psychiatrists. They are done by pediatrician. They are correlating AVGA score, baby's first 10 days development, and various other scores with future neural development of baby. They have started to understand it. We need to start dialogue with them and start giving the neonate medicine. In many pediatric ICU, or rather most pediatric ICU, they use melatonin liberally. And one of the biggest use of melatonin is seen in this age group. Few days old infant, few weeks old infant, and other things. So these people are already started using the treatment. We need to guide them. We need to teach them how to do it, and we need to teach them that we are better understanding people in this field, so they need to collaborate with us. Then in these group of people, in these areas, we need to collaborate with everyone catering to these people. The all the different kinds of pediatrician, child development centers. We need to lobby with the child right activists and other ones who would send the message of brain to the general population. Because while we reclaim our field, it is always based to approach to consumers, general population, rather than going through bureaucratic way of other specialties. We need to engage in that. Then comes the early childhood. When child starts showing early manifestation, means first 6 months. If we start teaching people that, if we start doing seminar and workshop on that, and if we start giving treatment during these periods, the neurodevelopmental trajectory can change. And that change would be our greatest ambassador. If we start giving, I am just giving an example. It is not applicable to every infant, but if we start giving, let's say, 0.5 ml or 0.7 ml of fluoxetine syrup, which is 20 mg per 5 ml, to an infant who is showing excessively cranky behavior, excessive irritability, who is clinging to mother and father very much, who is very finicky, and we showed a parent that within 1 or 2 months the child has opened up, the child has started talking better, the child has started communicating better. That is our biggest advertisement for the cause of our subject as well as for betterment of people. Then there are ways to create noise by social media and other things. I am not actually conversant of in Facebook or Instagram and other. Only for social media I use is WhatsApp, so I don't know that how people can do it, but I know that that space can be occupied and we can do it clinically. And as a doctor, we can start treating them early. We can start giving them treatment for a lot of things, and we can show the parents as well as the other professionals that by giving the treatment, we have been able to change the developmental trajectory of the infant or the toddler or the child. With this, I am stopping today's deliberation, and next 2 weeks later, it would be a very complex molecular presentation on how these changes are happening. Because today I wanted your undivided attention, but after 2 weeks, I would give you molecular and connectomic explanation of why this is happening. Thank you.
Yes, Aparna, you can take the questions now.
Yes, sir. First of all, thank you so much, Dr. Bhaskar, for taking us in a very stepwise manner and yet very lucidly, very clearly about the development of vulnerabilities right from conception up to the point a disorder can develop. And also for actually focusing on the fact that communication, collaboration, early management. And I think communication and collaboration are two of the skills that we as psychiatrists we have in our arsenal. And that is the one that we should utilize so that our patients do not become patients at all. So,
Yes.
thank you so much. It was a wonderful presentation, as usual. And there are already a couple of questions. So, first of all, this was asked that do all of these things always lead to mental health issues?
All of these things would always lead to brain issues. Question is how that would manifest. In some patients, it would manifest directly as obsessive compulsive personality trait, and following that, it would develop into recurrent dysphoria or impulsive compulsive behavior or other brain associated. In some, or rather many of them, it would not be. It would go into somewhere else. The brain pathway that is disturbed would not affect brain directly. It would go downstream. It would cause autonomic activation, and autonomic activation would lead to various other organ disturbances. Some of them would develop hypertension, that too young onset. Some of them would develop diabetes, young onset diabetes. Some of them would develop silent AMI, early AMI. Some of them would develop early stroke or CVA. Some of them would develop some other non-communicable disorder, metabolic syndrome, various other things. So, no, it is not always going to manifest as behavioral manifestation. Many a time, it would develop as other non-communicable disorder first, but then when that non-communicable disorder progress, it would start manifesting in brain. So brain would get involved either from the first, and brain science would come from the first, or they would come later.
Thank you. Dr. Nachiket has asked that are these complications indicative of shared genetic vulnerability, which is the maternal vulnerability manifesting symptoms because of a physiological load, or fetal systems which are actively interacting with the with the maternal system and thus more indicative of the fetal vulnerabilities and genetic makeup?
Both. The thing that I have omitted, and I have omitted deliberately, is no fetus can have de novo origin of disease. That is something I have not explained. Why? Because de novo origin cannot happen. There are maternal vulnerability, there are paternal vulnerability that is going to fetus, and then fetus develop its own mutation, and ultimately the final expression in a form of disorder or deviant trait, whatever we call it, happens. So mother already has vulnerability. So it is a shared genetic vulnerability manifestation. Maternal immune system, maternal neuroendocrine system, and maternal brain system already are vulnerable. And that vulnerability is compounded by fetus having the maternal vulnerability, developing some kind of de novo mutation, as well as some paternal influence. All these two different side of thing combine to create the fetomaternal imbalance, and ultimately the pregnancy signs that we see in women.
Okay. Another question, which was a part of the same, this was that is it, like you said, an immune interaction like a RH incompatibility?
Yes, but consider that RH incompatibility is happening in only one domain. This is a immunoneuroendocrine incompatibility. And the incompatibility is not all or none. RH incompatibility is all or none. Either accept or lose it. Here, there is variable amount of encroachment. Mother's immune system and endocrine system and maternal brain encroaches on fetal domain, fetal endocrine system, fetal brain, and fetus other system encroaches on maternal domain. Somewhere there is a dynamic equilibrium forms. Fetal cells go into maternal circulation and settle there. Maternal cells go into fetal circulation and settle there. And ultimately, there is a shared genetic vulnerability expression.
Another question asked was that is twin birth or even multiple births also a vulnerability?
Twin birth or multiple birth, whether it is a vulnerability or not, it is not really academically proven, or it is not really evidence-based way proven yet now, because there is one doctor who is known as Dr. Date in Nazi Germany. I forgot his name, some Miguel or something, who was Hitler's head of this type of genetic research, and he was notorious in concentration camp for his experiments on twins. He had found some way to manipulate twin birth. When he fled from Germany, he went into a place in Argentina. After his migration, coincidentally, the place started having more twin birth. Whether it is related or not, we don't know. So there is probably some way to manipulate twin birth. But is that a vulnerability feature or no? We don't know. We don't have that much information yet. I
I,
forgot the name of Dr. Date. Sorry.
I think it was
Mengel,
Dr. Mengel.
Mengel.
Dr. Joseph Mengel.
Yes, Joseph Mengele, right.
Yeah. Of course, Dr. Irene also asked a question that how do we do early detection and prevent progression? But then she, of course, reiterated saying that this has been answered in the presentation and thank you for the comprehensive elaboration. So, are there any more questions?
Dr. Malay, your inputs a little.
Yes.
Yeah, so basically it was a nice summary and a chronological uh, uh, perspective of how things unfold over a period of time. Lot of I mean, these are the phenotypes as you said, and the more important thing would be the next one wherein we discuss mechanisms, because this is where
Yes.
we would probably consider whatever kind of intervention we would, and probably think about what if this do continue, and how is the whatever vulnerability, how does it get converted into an illness, and how does that illness behave over time with whatever comorbid things, or how does it affect the lifespan and things like that. So one thing that has been pretty clear is that things are not linear, so to say. I mean,
Yes.
it is not just one gene, one locus on the chromosome, one disorder.
Impossible.
It's going to be a multiple number of things, and that it brings us to the question is what is the nature of illnesses? What is the nature of psychiatric illnesses? Are they just collections of symptoms, or do we need to look at illnesses differently in terms of what are the mechanisms involved? Because that is where our understanding will be more precise and our treatments will be more personalized and tailored. Because at till that time, I mean, see, what is happening is I had one experience wherein somebody was a developmental pediatrician, or somebody who who was dealing with exclusively children and adolescents. And the question was, well, there is this child who has been diagnosed to have symptoms of ADHD, and now the child is 18. And what will happen to this child who is on treatment with ADHD? What happens after 18? Do we continue treatment? Do we not continue treatment? This was what the parents had talked to that doctor, because now at 18 the child was adolescent, was had finished 12th and was now looking for further studies. And the answer given to him by this developmental pediatrician, child psychiatrist, was, I deal with only children and adolescents. Now, that doesn't make the disorder go away or treated, or it doesn't prevent any kind of, I mean, it doesn't alter the trajectory of the illness, because the more we understand illnesses, the more we will come to the conclusion, directly, indirectly, from our experience or from reading, that psychiatric disorders do not have a clear-cut beginning and they do not have a clear-cut end. What we see as remissions in our patients is that, well, the symptoms are, or maybe the system that is causing the problem is to an extent, let's say, controlled, but the underlying vulnerabilities, the underlying mechanisms are just there. And the same vulnerabilities, if I address at, let's say, 18, 35, or 65, are going to manifest differently and with different kinds of things, different kinds of combination of things. I mean, by combination, I don't mean only psychiatric comorbidity. I also mean the physical non-communicable disease part will also get involved. So very interesting times, and let's see what we can discuss in the next session. Over to you, Aparna.
Pranjal Tripathi has put a question. Can you read that?
Pranjal Tripathi has put a question that what are the chances in future where these vulnerabilities can be optimally quantified and precisely treated and prevented?
I'm going to disappoint him big time. Because the thing is, you have to understand that for this series, which I started 3 sessions ago, this is the 4th session. This series has made one thing clear, that so-called psychiatric symptoms arise from disorder of all 20,000 genes of human being and 100 plus open reading frame that are also capable of creating protein. And not only that, all the regulatory mechanism that are in the non-coding part of DNA, they are also involved. So we are talking about a humongously huge number of permutation and combination. Now, the problem of biology is, in a word, very simple. You cannot control it. Nobody can control it. Biology is nature, and nature would bypass any sort of regulation. I don't know how many of you have listened to the talk of NVIDIA head who talks that biology is now engineering. Biology can never become engineering because of this huge problem. In biology, 2 plus 2 is equal to 4 only if certain parameters align, certain conditions are fulfilled, and if that is not, then it would be negative infinity to positive infinity. So all biological reactions have the same caveat. They can happen and give this fixed result if only and only certain things are satisfied. If that is not satisfied, they would give different result. So this 20,000 gene, 100 plus open reading frame, and a huge epigenome that would never give same result in all conditions. So since there, we can never quantify every vulnerability. We would never be able to do it. So we are not looking at quantifying things. So if we are not looking at quantifying things, then how we are going to change the vulnerability? We would not be able to change the vulnerability. We would be able to do something else. The something else is we can tweak some little thing, change some little thing that would give the specific human being which is coming out of this genetic thing have certain advantage in certain areas. But would that be risk free? It is not. We are just children playing with bricks that are 1,000 times bigger and more complex than us. Let me give two examples. One is in China, a scientist was banned initially for causing CRISPR applied babies born. He has applied CRISPR to a group of babies, and those babies, in those babies, he has removed the HIV receptor, the receptor which binds HIV to human cell and let it infect it. He was very, very happy, and he is still happy because he's been released from jail and is made in charge of the same program. He says that he has cured chance of HIV in those babies. Unfortunately, that protein which he removed is a very important protein which helps in T cell maturation, B cell maturation, which helps in regulating the T cell mileage, the T cell lineage into differentiation of different T cells. So by removing that protein, has he given survival advantage of the baby, or is he giving a detriment? We don't know because we don't even know how the babies would grow up. So that is one example. The second example is humanity has multiple ancestors in its evolution in the past. We are Homo sapiens, but we carry Homo neanderthalis gene, we carry Homo denisovans gene, we carry a lot of other human ancestor gene. These genes have given us various advantages and disadvantages. There is a group of people who live in Tibetan Plateau. Tibetan Plateau is the highest livable environment in Earth. Those people who live there has high Denisovan DNA in their DNA. Sorry, high Denisovan gene in their DNA. This having high Denisovan DNA has the gene has given them ability to have increased oxygenation without leading to polycythemia and increased chance of thrombocytosis and thrombophilia. So these people has high level of oxygenation capacity at high altitude, but they don't develop polycythemia as a result of that. They don't develop high coagulation profile in response to high altitude. But if these people are now given a task of coming into our lowland and work there, they would simply die of a lot of things. So again, what I was trying to highlight is having one gene mutated, a set of gene mutated for adapting to a particular environment can make us more vulnerable to other environment, and we don't know. we are playing with something which is how much bigger than we, I don't know. I can just say, as a worshipper of that infinitely beautiful thing, that it is something which is so vast, so huge, that we don't have much knowledge to manipulate it. I hope I have not bored you, but this is the pure answer.
Thank you, sir. There's one more question that will psychotropics also help in diluting the risk of physical illnesses which may arise in the future?
Yes, they already do. There are thousands of evidence. Just do a simple customary Google search, not specialized search engine search like medical search engine. Just do a normal Google search and say the antidepressant in malignancy, antidepressants in immune autoimmunity, and you'd find a list of papers. Similarly, you can do the same thing with antipsychotic, and you'd come up with a lots of. And there are multiple evidences uh, still getting published in 2024, and many are already been accepted and going to be published in 2025. So yes, there are lots of evidences.
Somebody just said a very beautiful comment that someone's resilience is someone else's vulnerability.
Exactly.
But the way I would see it is that somebody's resilience to something is also his or her vulnerability to something else.
Yes.
So thank you so much. Thank you so much for your valuable comments also, Dr. Maledave sir. I would like to hand over the forum to Dr. Rajkumar sir.
Thank you, Dr. Aparna. Thank you, Bhaskar bhai. Thank you, Malay bhai. Thank you, friends. That brings to an end to this session today. The next session is going to be on the 8th of January because the fourth Saturday falls on Christmas Day.
Yes,
so
and we are going to
take
take a leave.
We'll take it on the 8th of January. We would also wish to thank the knowledge partners Alchem CNS Division for facilitating this web series. Thank you very much. Good night to one and all.
Good
Bye.
night.
Good night.